At this stage, I want to introduce Mr. Billy Nine. And Billy is a patient here in the Mallow Health Centre. And it's interesting when Edwina mentioned the idea of the small fires. And I think one thing we forget about all these standards and regulations and ivory towers that many of us may sit on every so often, that it is actually supposed to be about improving the care to the patient. And it is supposed to be about making their experience as users and consumers of the health services much, much better, and to continuously trying to improve that lot. But of course, we can only do that by actually communicating with them and listening to what they have to say. And I think it's commendable that Billy will just give us a few words on his experience of what they formed here as a patient forum, where the clinicians and the staff providing services listen to their patients and how they can improve those things. So just a few minutes on that, it might be interesting.
Please bear with me. It's been a long time since I've spoken in public. My name is Billy Nyan. My background has been auditing standards for UCAS accredited bodies in places like Northern Ireland, UK, and Russia, Cyprus, basically throughout the world. So 3 years ago, I had to retire, and I got involved here with David and Harry, various doctors, Tony, on a consultancy basis initially, but then as part of the I won't say customer, but patient focus group. So basically the remit was to develop a standard that would be cost effective, that would include the key aspects of HICWA requirements, and also we looked at JCI. And we put together a standard based on OSAS 18001. That's the International Occupational Health and Safety Assessment Specification. It's internationally recognized. So here in Mallow was the first primary care unit in the UK or Ireland to go for this standard. So the patient group, basically, we gave feedback to the doctors and vice versa. And remember, with the number of doctors here, you've got in excess of 300 years of cumulative experience and talent. So using that and using various patients and the input of people like Damien Casey, and the various doctors, bit by bit, we began to formulate a standard. Initially, we based it on the health and safety statement, which is a requirement for every practice under the HSA rules. So we upgraded the safety statements to begin with. Secondly, then, we looked at the ISO standards, and OSAS is an ISO standard now. It wasn't at the start, it was a specification. So we took all the critical points like quality improvement plans, KPIs, key process indicators. All these type of things are areas that doctors need to concentrate on because you get paid on the basis of a lot of these indicators. It means money. So working with Tony and Harry and David, we changed the language of the standard to suit the Irish scene. We tried to put in doctor's language, patient's language, something that everyone would understand. So when the primary care unit was set up here, for the first time, I'm from Mallow all my life, and I would have known all the doctors to see them around. But it's only when I came over here, I met them. I met the nurses, met the various support people, the admin staff, and over a period of the last number of years, we got to know a lot of people in the primary healthcare centre. So there was feedback coming from everyone effectively, and Damien Casey was carrying out audits of all the practices, not just the Red House or any single practice. So he went in and he'd have his checklist, and Damien maintained the standard. Now, we put in this standard for a fraction of the cost, and dare I say it, JCI, we could put it in for far, far less than the JCI costs. And still, we got third-party certification. In other words, we got an independent body to come in and register, certify MPHC. So all the practices here were registered independently, and then the fourth practice and MPHC in general. So you can see the certificates in the various practices. So it wasn't easy. There was a lot of talking to be done and a lot of explaining and trying to link up the lingo of industry with general practice. You know, we were basically talking different languages for a while. And a lot of things like KPIs, like I would have been very used to KPIs in industry. Like people like Schering Plough now, for example. You name it, Janssen, all these people are certified. Originally to ISO 9000, but it's now OSAS is the important one, and ISO 14001. So what else can I say? Like we've got a standard that addresses most of the HICWA stuff. In other words, the data control standard, the better care, better home, is it? Yeah, standard, and the control of infectious diseases. All of these are in our standard now here in MPHC. So what more can I say? If you have any questions? Yeah.
Thanks very much, Billy. Thanks for that. And I think it just shows that the resources that all the people in the different communities can bring to bringing standards and quality is certainly there. I'll open up to the floor now for any kind of questions or comments that people want to make to the speakers in this session on standards and quality in general. Any hands going up? Yep, just in the middle of the room there.
Brian Carr, GP Mitchelstown. I suppose just the talk on, I suppose, you know, standards, and I suppose the feeling as a GP on the ground, like it's the kind of feeling is that how do we do better? And I suppose the feeling is I can't work much harder. And I suppose one of the problems with general practice is that more, and you know, I suppose we are kind of the first line of call, like really 24 hours a day. Just to give you just an anecdotal example, yesterday, and this doesn't happen every day. One case was a lady who was married, 2 children, marriage kind of breaking up, was wondering about having a termination, had a termination, coming back from England, and just, you know, wondering did she make the right decision. So, you know, I suppose a genuine person, you know, she made kind of the decision because I suppose the marriage is breaking up. She had 2 children, and at the same time, she, you know, and you know, her life, I suppose, is, you know, this is going to take a good while to kind of come to terms. And just, as she said herself, she didn't realise she'd be grieving, and that's what she is. She thought to be just all done and dusted. And I suppose this doesn't happen every day, but this is one of the things that we as general practitioners, you know, make us different from, you know, I think other areas in medicine, that this kind of becomes our problem. And I suppose we, as the GP, we kind of take it on as it is our problem. And I suppose you balance that with the talk, and my initial feeling hearing these talks about improving standards. You know, I say, you know, unless we have the, you know, the support to deal with the problems that we're not qualified to deal with, and there's no, I suppose, obvious kind of solution to someone else handling these problems, the idea of us doing more, you know, feels, you know, like it's hard to listen to. And I suppose the other thing, just generally today, with, you know, this is, I suppose from a GP point of view, the problem with general practice is that it works, and it works well. And I suppose this is a problem from a political point of view. You know, there's much more mileage to be gained out of hearing that there are 2 extra people on trolleys in casualty than any real problem in general practice. And I suppose the politicians kind of make the decisions. And I suppose, you know, I don't know, it doesn't matter who's Minister for Health, but I suppose the problem is when major decisions like health come down to elections, it's very hard to see light. and at the same time, from the speakers this morning, there is, I suppose I suppose on one hand, general practitioners, we like what we do. We probably like it too much to our families and our friends in detriment. But I think, I suppose, in some way, like with this forum and whatever day is left, I suppose the message, how does the message, the good of what general practitioners do, and how can that be, I suppose, valued in the health service, and I suppose to some extent, I think, compared to our hospital consultant colleagues, because we're in business, we provide a pretty good service, but I think we don't really have an effective voice at the moment, and I think a forum like this, I suppose it's how to get, this is what the individual on the ground feels, how do we put value on that and get, a kind of an action plan to have, some of our needs and indeed patients met. Thank you.
Okay, thanks for that. I don't know if any of the panel want to take that. I mean, one of the things that perhaps just to maybe summarise one of the things that comes to my mind on these things is that I suppose everyone's very, very busy, and these things are seen like an extra imposition, and oftentimes it's the squeaky wheel gets all the attention. And when Edwina was talking about reporting the CEO of the HSE and the accountable officer and so on, and the statement of compliance, is that what are the main priority areas that are coming to light as part of that process, and is that the reason certain things are seen to be prioritised over areas that we know abundantly could be providing better care for patients? Edwina?
Gee, thanks for that. No, actually, that is the process now is bringing the clinical and social services issues to that table. It was never there before. We just talked about finance. But I really need to say to you, in my view, from my experiences, this shouldn't be an extra burden on you, and you shouldn't please lose the empathy that you always use with your patients. Anything that's going to take you away with further paperwork from the care and the delivery and the one-to-one that you're giving with your patient now, you shouldn't engage in. And I say that sincerely, because should never be the purpose of bringing in standards. The paperwork bit is the very last piece you do. It's the practice you are currently doing and how the standard of that practice, but that's your own professional standard of practice to start with. And it seems to me that it would be completely wrong, and I've seen this happen, absolutely happen, where people ended up doing all this reams of paperwork around standards, but actually, which I said to you there, that it isn't changing anything around quality or safety. But if you're giving a good service now, and if you're taking that time with that woman that you described who needs your time, that's very valuable, and that shouldn't be lost in any of this. So it shouldn't be seen as an extra burden. And I think that's what I was saying when I was talking about the Quality Patient Safety Directors and, Philip Crowley, who is a GP, that we're there to help you with any of those kind of things, because I would hate to think you were struggling with thinking you are been drawn away from ever that one-to-one relationship. And I suppose the other side of that too you're talking about is the gaps in your multidisciplinary team, because that woman needs more than you. And I don't mean, there should be someone she can go to, a counsellor, a grievance, bereavements, where she can be open about what she's grieving about at the moment, her termination. And that's the multidisciplinary team I'm talking about, and the help you need to do that. Is that there, and why isn't it there?
Okay, Brian?
Yeah,
sorry.
could I add something?
Yeah. Okay, sorry.
Sorry, just very briefly, and you'll forgive me, Edwina, I don't agree.
Okay, that's good.
That's just for the sake of it. I've been working with healthcare providers implementing regulation for 20 years. I have never once been involved in an organisation who had to fulfil standards that it did not pull away time from direct care. Not once. However, implemented correctly, after 12 months, and there's a very significant curve, it hits a peak after 6 months of screaming and crying, people not wanting to do it, saying, I did not sign up for this, I am here for the patient. That is the peak of the bad time after 6 months. After 12 months, that curve drops. after 18 months, almost without exception, if properly implemented, and this is reflective of the presentation we had from Jack earlier on this morning, people say, it was worthwhile because I've got that investment back, because I'm not chasing my tail, because I'm not doing things that I don't have to, that I'm able to work with the people in the multidisciplinary team better. But for that 12 months, you will suffer. But it's about making sure that you're not suffering for no reason
Or alone.
or alone.
Can I just,
That was my point.
Mary?
can I just add to it as well? I suppose,
fine, no.
because I very much hear what you're saying. I suppose one of the first things I would say is it's not even that there is an expectation that you improve what you're currently doing. What you're currently doing may be just fine. However, there is no measurement of that, and it's anecdotal. So what happens is, if you try to inform policy, influence the man who was standing here earlier on today, and he's trying to go into the Minister for Finance and get more money for certain things, or do any of the changes that were discussed here this morning, it's all just the anecdotal stuff. We're not looking to measure things. And one of the things that the IHI did, and again, I'm not sure if any of you are familiar with it, but they made it very practical, because, and I saw this as a nurse on the floor, I give the example sometimes that when a standard comes out or when a diktat comes from on high in some way, I'll just leave it as broad as that. What happens often, I'll give the example as when I was in the HSE, as an example. The letter would come from, maybe it was Laverne, and the letter would say, I need data on this because I need to assure myself to my master that things are okay. The letter was then sent from Laverne to the RDOs. The RDO sent the letter to the area managers. The area manager sent the letter to the GM. The GM sent the letter to the nurse. And guess who did the work? The person at the front line that was trying to do it all. What I want to do as part of what we're doing with the HICWA standards is actually have the things that we need to be measuring part of our everyday work anyway, not something added on to what you're already doing. And the type of scenario that you described there is a perfect example to me of how you are meeting one of the very important themes in the HICWA standards, which is person-centred care. Now, you don't need to use that particular anecdotal, but if you were saying when somebody walks in the door to you that you spend X number of time doing various things in your practice, and you spoke about the amount of time that you spent in communication, and somebody is trying to collate that for you, that's then evidence to say whether you need somebody else, whether you need the type of multidisciplinary people that Edwina is talking about, or whether things need to be done in a more efficient way to give you more time for those really, really important conversations that you're having with your patients. But the goal is to make sure that we're all working together with you to make sure that it's not an added burden and it's not an extra thing that you're having to do in addition to what you've already done, and that you're measuring it, and that you can then use that as leverage to get things. I was in a hospital recently, and they were saying they desperately needed another theatre because they were running into problems where there were certain times when there was a surgery cancelled because a C-section, emergency C-section came in, and I said, okay, right. And this was back when it was my old job, and I said, so how many times is that happening? Oh, we don't know. It's happening all the time. And I said, okay, that's fine. It's happening all the time. But if you give me the figures on it, if you measure that for one year, I can go then to the next person or to the finance person, and that kind of information can be given to whoever needs to make those decisions around funding. But they have evidence. They have hard facts to say why we need to be doing something. That's what standards are about. It's about measuring what we need to be actually doing.
Thanks. I've only got time for one question because we started a little bit late. Or do I have more, David? Well, that's my fault.
Just
no blame culture.
Just culture.
Brian, did you want to ask a question
one at the
earlier?
back.
Jack's going to do it.
Just two quick things, a question and a comment, if I may. First of all, the question is to Marie, and thank you for all the speakers here. As you're aware, the Care Quality Commission in the UK now, all practices have to register by April 2013. I'd like to hear if HICWA have any plans of kind of imposing a registration on practices in the next 2, 3, 5 years, or what's down the line there. And the second point I would make, and thanks to John because he has clarified it, it's pie in the sky to start talking about doing all of this work and to suggest that it's not going to put a lot more work. So please don't do that.
Absolutely.
But as the groups working in the area, could I suggest that the solution is actually there to your right hand, well, to my right hand side, it's refreshing to hear what Billy did with the group here. And they introduced something that to me added value. It was almost a lean version of standards. So I implore you, as you move forward, please don't not put in standards that are going to actually add no value whatsoever. So challenge yourselves, is it adding value? And the value I would suggest is, does it improve the outcomes of the patients? And if it doesn't, don't do it, please.
Jack, the answer to your question is the standards will be the same standards that have just been launched. It's the national standards for safer, better healthcare. They are principle-based standards, very broad standards. In terms of and even just the way you said the word imposing standards on people, even that is just so negative, and unfortunately that is because all we've had in this country up until now is regulatory framework regulation. But there will not be anything brought in that is of no added value. The people that will be implementing the standards, meeting the standards, will be helped all the way along. And it obviously it does take extra time, but that is the whole point of us saying that we are going to try to help people, even some of the lean methodologies you're talking about, that's part of the IHI training, teaching people how to do things in a more efficient way.
Brian, do you want to say something?
Just very quickly.
There's also a lady
Just
down
very
there.
quickly.
Yeah.
We've got to remember that this is your camp. We appreciate that. But there's other people coming in. I mean, we have the Medical Council via the ICGP. I mean, the levels that we're being asked to do it at, as you quite rightly pointed, we're the only ones who don't get paid when we go to these meetings. For example, the primary care meetings. The doctors are the only ones who are not paid. Everyone else getting time off in lieu. There's only so much of this stuff you can cut down, you know, and ask us to take reductions and reductions. We were asked in the Mary Harney times to invest in our practices. You know, so I mean, there has to be a stop somewhere, and I think it was refreshing to hear that there's a new, slimmer way of doing things, and I really laud that your enthusiasm, and I hope it works. But you've got to remember, this is your tent. There's about 7 other tents out there, and we have to pay homage to them all.
Yeah, and that is why we're all talking together as well.
Alona Duffy, GPMon. And I suppose one thing I'm listening to here, and we hear all about standards of care, which are measured, I suppose, on definite outcomes, like is your diabetic patient having their HbA1c checked, is your hypertensive controlled. But we're forgetting about standards of caring, and that's exactly what my colleague here to the left is talking about. And I think that we've seen in secondary care, because of the demands placed on them, there is a drop in the standard of caring. That is still in primary care. And we don't want to see ourselves be changed. And I look to the NHS in the UK, where I have a sister who can get an appointment tomorrow for her smear, but will have to wait 3 weeks to see the GP about her cough. I have patients, I'm on the board, I have patients who come down and say, well, I see my GP in the north for the quick thing when I know there's nothing, but if it's something I'm worried about, I'll come down because I get the time here. And that's what I'm afraid we're going to lose.
Me too.
Okay.
There's a lady at
Yeah.
the bottom.
And the back.
Just very quickly, could I ask Marie, please, if there is a timescale for the development of standards and regulation for the home care sector, particularly for people with dementia?
There have been talked about. There's no time frame as of right now. I think really the main thrust for next year is around, and this is on the regulation side, so it's not actually my side of the house, but I know what they're looking at now is the disability standards, the child protection standards, and then the second cycle of the nursing homes. But I know there is a lot of talk around the home care as well.
Thank you.
Can I get a plug in there as well? If anyone is very anxious to go working towards home care standards, the JCI home care standards were launched earlier this year, and 3 home care organisations in Ireland are actually well on their way to fulfilling them, and they have been mapped against to ensure they're in line with HICWA as well. Thanks for the plug.
Okay, one last question then down the back. There you go.
Just one question on the standards. There's standards coming out from so many organisations, and if we go voluntary standards with either JCI or CHKS or whoever it may be, and we get the accreditation from that body, are HICWA going to recognise that? Because we don't have the time or the resources. The standards are different. I've seen them. They are different across. The broad outline of it is the same, and the aim of it and the objective is the same. But to ask companies and us as companies to start applying different standards for the same outcomes, I just wonder, are HICWA going to recognise practices that have already got voluntary accreditation?
I'll answer that very, very quickly. HICWA is going to recognise any and all efforts to improve quality in your organisation. whether that be the fact that you've gone down the road of actually getting accreditation, or whether you have just put your local standards in place, the type that Billy is talking about here, HIC will recognise all of those standards as efforts that you have made towards meeting the standards and towards improving care. Any effort that you make to improve care has got to be a good one.
And
Can I
again,
impose a standard on time, if you don't mind?
Yes.
Okay.
Okay,
Turn-
thanks. Yeah, going to call it to a cause. Sorry now, because we did start a little bit late on that, and you can see that there, just to get my own plug in, as college for the GPs, I think we very much understand all of the challenges GPs have to face in trying to deal with all these issues that are going on. I suppose one of the positive issues that we're involved and discussing very much with the HSE and HICWA and everybody else involved in this space to try and bring some context and some pragmatic approaches to implementation of these things. And so that has to be timescale, it has to be resources, and it has to be funding to make these things happen. So I think we just need to keep advocating for that.